Good afternoon. My brief today is to contribute to the wealth of healthcare-related insights we've heard so far through the lens of my admittedly somewhat less glamorous area of expertise, which is corporate governance. As a governance lawyer specialising in healthcare organisations, I passionately believe that the governance frameworks in place in healthcare systems can and do have an impact on outcomes at the front line. This very much mirrors what Robert Watt told us earlier in relation to the importance of leadership and culture in our healthcare system. That's why I'm going to speak today about a major forthcoming reform of our public healthcare system, the establishment of regional health areas, or RHAs, under Sláintecare. I believe that the implementation of a cogent governance framework for the RHAs can bring about service improvements for patients, and again, to use Robert's words, to build a healthcare system we can all be proud of. That's why today I want to talk to you about the regional health areas, what they are, why they matter, and what they might mean for you. The Sláintecare RHA reform will have an effect on everyone engaged in healthcare services. It will affect everyone in this room. It ought therefore to be considered by you now as part of your ongoing planning and risk management functions. Some of you are funded or part funded by the HSE. Some of you contract with the HSE. Some of you supply the HSE. Some of us are or will be patients within the health service or have loved ones who are. Everyone will be impacted by the change. Indeed, the Oireachtas Joint Committee on Health has described the establishment of the regional health areas as probably one of the most significant reforms ever undertaken in the public service. I'm going to tell you a bit about what the planned RHA establishment entails and what you can expect. I should preface my explanation by saying that Mason Hayes and Curran have not advised the HSE on this matter, so my observations are given from the perspective of a reasonably informed outsider. My second and last caveat is that it's important to be cognizant that, to use a lawyer's expression, nothing is agreed until everything is agreed. By this I mean that the RHAs are in a phase of policy planning, and that plan is on the desk of the Minister and then has to go to Cabinet. As we know, plans sometimes change right up to implementation, and the description I give today should be regarded in that context. As you'll know, our public health system at present is organised across 7 hospital groups and 9 community healthcare organisations, the CHOs. What this means in reality, as we've heard repeatedly today, is that we have one system in Ireland for public hospital care and a separate infrastructure for non-acute, that is to say other healthcare needs in the community and for mental health. Against that context, the government made a decision in 2019 on foot of the Sláintecare report to address this siloing of acute and non-acute care by reconfiguring the HSE to align with 6 regional geographies known as the regional health areas. I'll put the map of the geographies up on screen in a moment. In this way, the RHAs are intended to effect a moderate decentralisation of the public healthcare system from HSE centre into the regions, with decisions affecting patients being taken as close to the patient as is possible. The aim is that under the RHAs, all the right people are now working in the same system. This will enable clinicians and others to look across the full gambit of healthcare services that might be required by a particular person in a particular location, and address those healthcare needs in a seamless and streamlined way. The first aim of the reform is that there ought not to be a wall or block if a patient's requirements span both hospital and community healthcare needs. Its second aim is to meaningfully devolve into the regions responsibility and accountability for healthcare provision within each region. It's hoped that one regional healthcare area structure per region with its own budget will result in leadership, corporate governance and management that's accountable and transparent, leading to greater efficiency and innovation at local level. Services are expected to be delivered in line with national direction, but responsive to local need. This goal resonates with what we heard from Bernard Gloucester's video. on leading for and with purpose within our healthcare service. I'll now give you some detail on the status of the plan. In terms of work completed to date and the establishment of the regional health areas, a lot of planning and evaluation has been carried out. A detailed business case has been published, and an advisory group has reported to the Minister for Health. The RHA Implementation Plan, which is the document that will bring the RHAs to life, is in final form. It's with the Minister for Health for consideration, with publication expected, although we don't yet have a committed publication date. We understand that implementation is targeted for later into 2023 or possibly into 2024, with CEO roles for each individual RHA to be filled shortly. So we know regional health areas are coming, and we know they're coming quite soon. The next key question is, what might it look like for those of us that will be interacting with the HSE and the RHAs once they're rolled out? The legal structure selected for the RHAs is called the HSE local model. This means that the RHAs will exist as localised divisions of the HSE. The RHAs will not have a separate legal status or a separate legal board. The HSE Centre will provide centralised functions, such as procurement and IT, to facilitate the use of shared services at national level. A separation model had been mooted, which would have had separate boards and legal personality, but it was deemed too disruptive to the health service, which is quite understandable. The documentation indicates that the RHAs will have substantial autonomy, each led by an RHA CEO. The RHAs will be responsible for understanding the needs of their own populations and for ensuring the delivery of effective services in response. To be enabled to do so, it's intended that the RHAs will necessarily have appropriate authority and control over key resources. This means that the intention is that they will get to decide what is needed within their region. For example, if a region is expecting an increasingly aged population, they should be able to plan for the health services that are needed to align with that expected local need. The hope is that it will be quicker and more direct than the current system. As ever, the devil will be in the detail in relation to the precise implementation plan, which is where we will be given more detail on the scope of decision-making and ownership that each region will have, including in relation to budgets. Which brings us back to corporate governance. One of the core objectives of the RHAs is to improve corporate governance and accountability in the health service. In the context of the model that they've selected, the HSE local model, my focus is on how corporate governance can be optimised for the benefit of patients and broader society. I find it interesting that in the context of regional health areas, speaking this morning, Robert Watt honed in on structures, accountability, leadership, culture and people as keys to the success of this reform. To me, each of these words is a component of governance. And the governance structure within the new RHAs, and indeed within the HSE overall, is therefore key to the successful implementation of this key reform. I really want to return to why this matters. To me, it's not actually about governance. Governance is merely the vessel. It's actually about public health. Even the expression public health suffers from being both generic and sanitised. What we're really talking about here are sick adults and children who need services and support from a well-run healthcare system. As I said at the outset, I believe that the implementation of a cogent and coherent framework within the regional health areas can bring about service improvements for patients. The HSE currently gets a lot of flack from a sometimes frustrated public and indeed media. The implementation of the regional health areas offers a new opportunity to design a meaningful subsidiary governance system which can streamline management and impose effective governance structures. To my mind, this would feed into so much of what we've already heard today on the themes of leadership, ownership, and partnership. From my work in advising healthcare boards, I know that we really want to see clear lines of accountability and reporting down to the individual patient without getting bogged down by multiple or contradictory reporting lines. To speak very simplistically about it, if the top is too far away or the top table is not within the line of sight of those providing the service, this can be an indication that clarity of governance could be improved. As Fergal told us earlier, in times of crisis, or indeed at all times, people want to know that someone's in charge and they want to know who's in charge. I would add to this that they want to see the people who are in charge. To me, that has to start with governance or the board. Although our public healthcare system has many distinctive features, not least of which is its symbiotic relationship with the Department of Health, I feel that from a governance perspective, there's much that can be learned from our voluntary hospital governance, with its esprit de corps as described by Fergal. The challenge in the context of the HSE and the new regional health areas is to extrapolate an effective governance model in the public context and at scale. Schemes of delegation, reservations of power, and governance mapping can all be good tools. I would also give serious consideration to the role of the HSE board and to whether board subcommittees could be put in place to operate as a feed-through from the RHAs. What I hope the regional health areas will allow is for well-defined governance structures and for governance which happens in a live way and close to the patient. So to conclude, what next steps can we expect? The Minister will announce the RHA implementation plan once passed through Cabinet, and this is really our key data in relation to what's coming. You should talk to your management and boards, talk to your advisors, and further assess what it means for you once the detail is apparent. Remember, this may all happen relatively quickly, and by the time we reconvene here next year, it'll hopefully be a reality. Thank you very much.